I welcome you all for this 7th webinar of clinical genetics by the Pediatric Academy of Telangana State. See, every month, every first Sunday, it's going on. Webinars are going on with a strong motto, say to help the postgraduates and practicing pediatricians also to know about the basic genetics and also the different case scenarios, and also apply in their practice, and when to refer the case or when to solve the problems. So they should know the things. So for this, our president, his presidential action plan of PATS is one of this clinical webinar. So I request now Dr. Sunkoj Bhaskar sir to say a few words.
Thank you, Dr. Sridhar, for your sweet words. Good morning, all, and I welcome the faculty and all the participants, and particularly Dr. R.K. from Vizag. At the outset, my sincere condolences to the family of Madam Dr. Prajna Rangana. Unfortunately, we lost him last month. That was the reason why she missed last time. Otherwise, she is the backbone of this entire 12 sessions planning and as well execution, and bringing top-notch faculty members. Once again, on behalf of entire Telangana Pediatrics, I convey my sincere thanks to Dr. Prajna. And as you all know, we had completed the first half of the year. The first 6 sessions are over. Now we are into the 7th session. I found it's really useful in our day-to-day clinical practice, particularly for practicing pediatricians. We know the importance and significance of the genetics in clinical practice, and now we are sensitive when to refer, when not to delay in referring the case. So many genetic cases we are seeing due to increased awareness among the pediatricians. So last time we had a good presentation by Dr. Karthik Bharadwaj on molecular genetics tests, their indications and interpretations in our pediatric practice. But we felt the absence of our convener, Dr. Krishna. And this time, this is really one of the few interesting, very interesting, all were interesting, but this is more interesting. For clinical utility is next generation sequencing applications and interpretation again in pediatric practice by none other than our senior member from Hyderabad, Dr. Ashwin Dalal, head of diagnostic division at the very prestigious CDFD Hyderabad. So we welcome you, sir, and over to Dr. Sridhar and Dr. Prajna Madam to take over the proceedings. Once again, I thank you, one and all.
Thank you, sir. I request Dr. Vijay Kumar, sir, President-elect of PATS, to say a few words before starting the program, sir. Please. Sir, Vijay Kumar, sir. Vijay Kumar, sir. Okay, I think he's not there. So, important message. There are the video recordings on the YouTube. If the people who had missed the sessions in last month or previous months, you can go to the YouTube and serve that 6th webinar of clinical genetics. It will be there, or fifth webinar of clinical genetics, it will be there. So every episode will be on the YouTube line. So you can, whenever you can have a time, you can go through. So
that recap, we'll now move on to the topic for the day, which is next generation sequencing, its applications and interpretation in pediatric practice. And we are really fortunate and happy to have Dr. Ashwin Dalal here to give this talk. So I'm sure Dr. Ashwin is known to most of you and really doesn't need any introduction. He is the head of the diagnostics division of the Center for DNA Fingerprinting and Diagnostics in Hyderabad. He has done his MD Pediatrics from Goa Medical College and DM in Medical Genetics from Sanjay Gandhi PGI, Lucknow. He is also adjunct visiting professor in the Department of Medical Genetics at Kasturba Medical College, Manipal. He's a prolific author, also involved in a lot of research projects. He's also involved in multiple task forces and expert committees of the Department of Biotechnology, the Indian Council of Medical Research, SERB, and so many other government agencies. He has more than 170 publications to his credit, and his areas of interest include exome genome sequencing for recessive disorders, chromosomal breakpoint characterization, and genetic analysis in lysosomal storage disorders. Dr. Ashwin, thank you so much for agreeing to give this talk today and sparing your valuable time. And over to you, Dr. Ashwin.
Thank you, Dr. Pradnya, and thank you, Dr. Bhaskar and the team for inviting me today. So Dr. Pradnya has given nicely introduction of Sanger sequencing, how it can be used in clinical diagnostics, prenatal diagnostics, and we have been doing this for last so many years. However, every investigation has some disadvantages, and that is how the new technology, that is next generation sequencing, came up. And today we are going to discuss about this particular technology. Many times it happens that it looks very complicated, and then you don't tend to go into details of newer technologies, and especially because these new technologies have not really come into the medical teaching, and hence many of our pediatrician colleagues are going to really hear about these technologies once they go into practice, and that time then it becomes difficult to go back and understand the nitty-gritties. So, but it is important, and we have to consider it something like what used to happen in our era when we did MBBS or MD pediatrics. There was no mention of these newer drugs, but once you come into practice, then you start understanding these newer drugs, how they act, what is their mechanism of action, how they can be used. And the same is with the next generation sequencing, that you really cannot run away from this. Every pediatrician is going to order for a next generation sequencing investigation, or is going to see a report done based on NGS. And hence it is very important that we all are aware of this new technology and how to interpret the results when they come to us. And that is what we'll try to do today, trying to understand how to interpret the results, because many of these tests are done by standalone labs and not really labs in institute, and there are so many different levels of expertise of these labs, the types of reports that come out, and hence it is very important that the pediatricians, the practicing clinicians, are at least aware of some of the terms or how interpretation of variant is done. And if you could contribute into this and put in your little effort, we will see by some of the examples today how we may end up doing more harm to the patient if we totally rely on the laboratory given report. And that is why it is more and more pertinent that we, the practicing clinicians, are aware of these terms, are able to discuss about these terms, discuss about any doubts that may come up regarding the interpretation of the variant in your patient. And ultimately, we all hope that these all new technologies really help the patients in better ways. So today we will talk about initially briefly about what is this new technology, how is it different from Sanger, and in the second part of the talk we'll talk about how do we go about interpreting the variants, which usually is done by the lab, but when you read the report you will be able to understand better if you know how these variants are reported, followed by two case presentations to bring out the nitty-gritties related to the new technology. So genetic testing, if you have to define, it's basically analysis of DNA in its various forms, and we have seen just now that we can analyze this DNA at the level of chromosome, at the level of the DNA, or at the level of the protein. Now, when we analyze the DNA at the level of mutations at the level of DNA, it is important to know what are we looking for. So in humans, we have these three types of mutations: the point mutations, the triplet repeat expansion or contraction, and the deletion duplication. And specific diseases have these mutations common, like beta thalassemia, cystic fibrosis. Most of the patients have point mutations. Huntington disease, spinocerebellar ataxia, or Fragile X syndrome, they have the triplet repeat expansions. And common diseases like Duchenne muscular dystrophy, spinal muscular atrophy, they have large deletion duplication as the common mechanism. Now, why it is important to know this is because every type of mutation needs a different kind of test. The gold standard for point mutation is in Sanger sequencing, and we have seen just now in detail about how Sanger sequencing is really helpful to identify the point mutations. For the triplet repeat disorders, we have tests called short PCR and triplet prime PCR. And for the large deletion duplication, we have tests like the MLPA or the array comparative genomic hybridization. So we can see that there is no one test that can detect all these types of mutations, and that is the great hope that every clinician has, that if one test can be done which can detect everything, then that would be really a ideal test. And we hope in near future we would have such a genetic test which can detect all these types of mutation. But as of now, we have to rely on our provisional diagnosis to decide which type of test is to be done. So Sanger sequencing, we saw just now that here we decide based on the part of DNA that we sequence, we design primers in that particular region, do a PCR followed by a special PCR using dideoxynucleotides. And in the capillary electrophoresis, we get these nice ATGC peaks, which we can visually analyze. However, Sanger sequencing has its own problems. Although it is very useful in many of the scenarios, but if we are dealing with a patient with an unknown genetic disease where we don't know what is the cause, or if it is a very large gene like osteogenesis imperfecta, 2 genes consist of 100 exons, so you'll have to do 100 PCRs and 100 Sangers. Or if it is a disease caused by multiple genes, like Bardet-Biedl syndrome is caused by more than 9 genes. In all such situations where Sanger needs prior knowledge of genome, and as we saw, only 500 to 1000 base pairs can be sequenced at a time. And if you have to do a large amount of sequencing, Sanger becomes costly and labor intensive. And that is why we had this new type of technology called as the next generation sequencing or massively parallel sequencing, where again you start with the genomic DNA. But here, instead of deciding which part of the DNA is to be sequenced, we just chop it into small pieces, do adapter ligation, a few PCRs, and basically we massively sequence everything. All these small fragments are sequenced together, and then the bioinformatic analysis helps us to put this all together to identify the mutation. Now, why this has come into routine practice is because of the drastic decrease in cost. The first human genome sequencing cost us about $2.7 billion in the 2000s. And today you can do a whole genome sequencing humans for about 30,000 rupees, or a exome sequencing for 10 or 12,000 rupees. So that's the drastic decrease in the cost which has brought this into routine clinical practice. Next generation sequencing also has its own problems for identification of variants, and we will see that in the subsequent slides why this becomes a problem. So how do we apply this next generation sequencing, different sequencing technologies in the routine clinical practice? So we can either, if we consider this watermelon as the whole genome of 3.2 gigabases, we can either sequence the whole genome, or we can sequence a slice of this genome, what we call is the exome. Exome is only 1% of the genome, but this 1% consists of 85% of disease causing mutations. So it's much cheaper to sequence a exome compared to genome. That is why mostly we use genome sequencing in routine practice. Or you can sequence a gene panel, that is a small number of genes which are known to cause a particular phenotype, or Sanger sequencing, which just sequences each exon of a single gene. So that is how we can imagine the different types of sequencing technologies that help us in doing a diagnosis. So what's the utility of panel sequencing or targeted sequencing? This helps us in sequencing a group of genes, like if you are suspecting cardiomyopathy or deafness or blindness or inherited cancer. All these panels were available in past. Nowadays we don't go for these panels because the cost of whole exome sequencing has dropped so much. However, like this is an example of an inherited cancer panel where we have the BRCA1, BRCA2, all related genes. So the clinical utility of panel was really in sequencing large genes like DMD, or for testing or for a group of genes. And then it became clear that the panel is always incomplete, and that is how we had this clinical exome panel, which many of you must have ordered Some of you might be ordering still now. So clinical exome panel basically refers to panel of all genes known to cause a human disease. So in our cells, we have about 19,500 genes, but we know diseases only for about 7 to 8,000 genes. So the remaining 13,000 genes, we still don't know what disease they cause. And hence a exome panel was developed of only those 7,000 genes, which was able to do the diagnosis. However, the cost difference between the clinical exome and the whole exome has dropped
Sir,
so
there
much
is continuous disturbance. Somebody is speaking. Can somebody mute them? Continuous disturbance. Okay, sir.
So the clinical exome panel basically is a panel of about 7,500 genes known to cause any human disease. But slowly this is going out of practice, and I would recommend to all of you that if you really want to do sequencing using next generation sequencing, then please go for a whole exome sequencing. So how exome is different from genome? If you look at, it's just 1% of the human genome. It's much cheaper to sequence a exome. And you can see when you sequence a exome, you end up with about 22,000 variants. As opposed to that, in a genome, you will get about 22 lakh variants. Finding one in 22,000 is much more easier, much more feasible. However, slowly we will be going on to whole genome sequencing probably in near future, and we will see how that is happening. So the clinical utility of exome sequencing really is in screening for mutations where we do not know what kind of disease we are dealing with. And so let's see an example here. We had this particular patient, a 6-year-old male born to non-consanguineous parents. He was overweight baby, 4.2 kg, delivered by cesarean. He had prolonged jaundice with documented hypoglycemia in neonatal period. There was hepatomegaly and renomegaly and normal milestones, generalized overgrowth with height, weight, head circumference more than 95th centile. Putting all these clinical phenotypes together, we have a working diagnosis of a condition called as Beckwith-Wiedemann syndrome. Now, why this condition is important is because it helps us to understand how complex genetics can be. So Beckwith-Wiedemann syndrome is a condition which can be caused due to multiple different types of genetic mechanisms. It can be caused due to a chromosomal translocation. So we did a karyotype that was normal. It can be caused by a deletion at the Beckwith-Wiedemann locus. So we did a microarray CGH and that was normal. This is an imprinted gene, hence methylation analysis was done at IC1 locus. That was also normal. And Beckwith-Wiedemann can be caused by point mutations in CDKN1C gene. And hence Sanger sequencing done for this gene also was normal. So you can imagine multiple different mechanisms can lead to the same phenotype, and we have to do all these different tests for each of the mechanisms. Now, once everything was negative, we took this patient up for exome sequencing, and you can see you end up with about 26,000 variants. And then through different levels of filtering, we ultimately identified this one particular variant in a gene called as GPC3 gene. This GPC3 gene lies on the X chromosome, so it's a hemizygous single base deletion. So this single base deletion you can see here in the Sanger sequencing. In normal person, there are two T's side by side. In the patient, one T is deleted, it's a hemizygous deletion, and mother being carrier because it is on X chromosome, she is a carrier for this deletion. And this GPC3 gene is known to cause a disease called as Simpson-Golabi-Behemel syndrome. Now, if you go on OMIM and check for the clinical phenotype, a lot of phenotype overlaps with Beckwith-Wiedemann syndrome. And that is the importance that clinically we really cannot differentiate among all these syndromes. And exome sequencing really helps us to pinpoint the diagnosis, which can now be used for doing prenatal diagnosis in this family, as well as we have a definitive diagnosis for this patient. This is another clinical situation where we had this patient with global developmental delay. You can see this very short stubby fingers. In the X-ray, there was large metaphysis and epiphysis. So overall, surely it looked like a genetic disorder because multiple different organ systems are involved. However, when we did the karyotype, microarray and exome, everything was negative. And I'm sure this you all must be facing, that many times you get a negative report in a exome. So why do we get a negative report in exome? It could either be because of technical limitations of the exome. We saw that exome is 1% of genome. So we are fishing out, we are capturing the exome out of genome. And whenever you capture, there is always going to be something left behind. Similarly, the first exons are GC rich, and many times the exome does not cover them. Or the causative variant might be in the intron or in the structural variants or triplet repeat disorder that we saw earlier by mitochondrial genes. So all these issues may give a negative exome report even though it's a genetic disorder. Similarly, there can be interpretation challenges. If you are not given correct phenotype to the laboratory, then they may not be able to find the variant. Or if there is a VOUS, there are non-Mendelian mechanisms like uniparental disomy or oligogenic inheritance, or if there are novel gene disease associations or phenocopies, that means disease is caused by environmental factors which look similar to the genetic disease. For all these reasons, you may get a negative exome report. And hence, please remember, just a negative exome report does not mean that the patient does not have a genetic disorder. It's always good to pursue further using other tests to get the diagnosis. So what next? After exome, the next what is coming up is the whole genome sequencing, that is sequencing of the full 3.2 gigabases. It generates a huge amount of data. But what is the advantage of genome sequencing is it is uniform coverage, non-coding regions are covered, and structural variation tandem repeats are also covered. So it is possibly going to be the one-step sequencing modality for all variations that I spoke earlier, that it will be one test which can detect all different types of mutations. So let's see how we can use it. Like this is a patient, you can see 4-year-old male child who came to us with short stature, anemia, thrombocytopenia, and the skeletal survey revealed this density increase in the bones. All bones are showing increased density with marble, the sandwich vertebrae, and the bone in bone appearance. This is classical of osteopetrosis. However, osteopetrosis is known to cause by a few genes, but solo exome sequencing came without any significant variant. Because we were very sure of the genetic diagnosis, we went ahead with a genome sequencing, and that revealed a very large homozygous deletion in a known gene known to cause osteopetrosis, SNX10, covering the exon 1. Now we said exon 1 is many times not covered in the exome, and hence it was missed in the exome, which could be very easily detected in the genome. And this was then again confirmed by doing Sanger as well as doing a real-time PCR from the cDNA. So what we need to understand is that many times what exome might miss, the genome might be able to detect. So the utility of genome sequencing as of now in the clinic is mainly to get a good exome out of the genome because of uniform coverage, to get non-coding variants which are known, and to get some of the structural variants. But what is very important to remember is that if you do a genome sequencing after exome sequencing, the additional yield is only about 10 to 15%. So it is always important not to jump to genome sequencing after exome sequencing. I am especially telling you this because many of the company representatives might be coming to you and telling you that after exome, please do a genome sequencing. You will end up spending a lot, but the additional yield is going to be very low. So what is the good use is that in future, probably instead of exome, if we start doing genome sequencing, that is going to be a more ideal use of genome rather than doing a genome sequencing after exome sequencing. Genome sequencing also has its own problems. Although we may find the variant, we still don't know how to interpret many of the intronic or the extragenic variants, and the cost also is very high for genome sequencing. And now a lot of other things are going to come up in future, like transcriptome sequencing, metabolome, methylome. We all have to be ready to understand all these new technologies. So in summary, for this part of the talk, the conventional techniques like Sanger and MLPA do help us in identifying common mutations, but genomics-based tests really help us identify when we don't know what we are looking for. And here the clinical correlation of variant is very important. So we have understood what is the new technology, that is next generation sequencing. Now let us go on to see how do we interpret the variants, because these variants will come reported in the report that you get from the laboratory, and you really need to see whether it is really the variant that you are looking for in your patient. So why do we need to interpret a variant? So here if we see this picture, in the first go, this picture really looks like few dried leaves, but you can see actually it's a chameleon which has taken the shape and color of the leaves. And so this chameleon is going to be a very dangerous for the small insect around. Similarly, you can see this picture here where we all would not really be doing this, but this person is very easily sitting with this dangerous animal. So why this is important is that many of the harmless looking variants can be really disease causing. Like you can see here, this is a synonymous variant. There is no change in the amino acid. It is only a nucleotide variant, but it can cause such a severe disease like Hutchinson-Gilford progeria. And on the other hand, a harmful looking variant can be a normal polymorphism, like a stop codon can be a polymorphism. Hence, it is very important that if a laboratory just interprets just because it is a stop codon, it is disease causing, that may not always be the scenario. So that is why we need to know how to interpret the variant using certain rules that are followed. So what are the different terms that you may be reading in the reports? One is a variation, that is the difference in DNA among different individuals. Mutation was the old term that we used to use, but we no longer use the word mutation because of its connotation towards mutants, and also with patients we avoid using the term mutation. So we call it as a pathogenic variation or a benign variation. And polymorphism refers to all the normal alleles which are different among each of us. So if a variant is present in more than 1% of the population, we call it as a polymorphism because it is usually a non-disease causing variant. So how do we go about interpreting a variant? So these are the 6 steps which we can use in interpreting. These are the same steps which the laboratory uses, and all these 6 steps will be mentioned in the report, in the paragraph that is written under the report, where they will write about each of these evidences that they have used for interpreting the variant. And you also in your clinic can use these same 6 steps to interpret the variant that has been given to you in the report. So let us see each of these 6 steps, how we go about using them. The first one is information about location or functional effect of the variant. So if you look at the gene consists of the promoter region followed by the transcription initiation start site and the translation initiation start site. So this part is called as the 5' untranslated region. Then we have the exon 1, the intron 1, exon 2, intron 2, exon 3, and then the stop codon where the exon ends. And then there is this 3' untranslated region. And at each of these exon intron junction, we have these sequences called as consensus sequences GT and AG. So from the location point of view, the mutation or the variant can be exonic, intronic, splice site, 3' UTR, 5' UTR, promoter or enhancer. Typically, we consider the exonic variants and the splice site variants to be more likely to be disease causing, and the other variants in the regulatory regions to be less likely to be disease causing. Similarly, on the functional effect based classification, we can have the variant as a missense where there is change of amino acid. Nonsense means there is a premature stop codon. Frame shift, because of deletion or duplication, the full amino acid frame changes. In frame means it's a 3 or a 6 or a 9 base pair deletion where the frame does not change. And silent mutation or synonymous mutation means where the nucleotide changes but the amino acid is not changing. So overall, we consider the nonsense and the frame shift mutations as loss of function mutations and more likely to be disease causing, and the missense and the silent mutations are the less likely to be disease causing. So this is a functional effect and location based classification of variant, which gives us some indication whether it is likely to be a disease causing variant or not. The second evidence we use is the frequency of this variant in normal population. How frequent is this variant in normal population? And why we need to remember this is because if we look at the human genome and the chimpanzee genome, then it is 99% same. Similarly, if you look at the genomes of different individuals on this earth, then we all are 99.9% same. So it is just this 0.1% difference that makes us all different from each other. And this 0.1% difference is different in different groups of individuals. So to know the population frequency, we need the data from each population because each of these 0.1% difference is different in the different populations. So what we are looking for in single gene disorders is basically, if we look at the effect size on the y-axis and the frequency on x-axis, we are looking at high effect and low frequency alleles. So we want the mutations which are very low in population. And to know this frequency, we need the databases. So a lot of population level databases are available, like the 1000 Genome, the Nomad, and various Genome Asia and other population specific databases. All these databases have their own websites. And in India also, different efforts were made to make these databases. We ourselves had made a database of about 1500 exomes that we had put together because we did not have a large database from India to do the analysis. However, all the countries have done their own database of the genomic variants in population, but they do not remain relevant to India because the Indian population is very different from all these countries. And that is why the Department of Biotechnology had undertaken this Genome India project, which was unveiled in January 25 by our Honorable Prime Minister. And this consists of 10,000 Indian genomes that were sequenced. And this data is really going to be very helpful to us to interpret the variants that we identify in the patients. The next evidence is whether this variant is reported in similar cases in past. So if a patient with similar phenotype has this same variant, then we are sure that it is a disease causing variant. And this can be searched in various databases like OMIM, ClinVar, PubMed, or the paid databases like Human Gene Mutation Database. The next evidence that the lab uses is the pathogenicity prediction tools. So these are software which help us to detect whether a variant is likely to be pathogenic. And these software use various different evidences like conservation of the amino acids or chemical properties or structure of the protein. Based on this, there are more than 100 such tools available, and they all do prediction. They just predict, they are not the final answer. They predict whether a variant is likely to be disease causing. Now we have collected all these evidences like a detective, and now we need to put together all these evidences like a judge, and that is where we use the American College of Medical Genetics and Genomics guidelines to put all these variants together to ultimately classify the variant into one of these 5 categories. So you must have seen in all the reports that the variant is either classified as pathogenic, likely pathogenic, or a variant of uncertain significance. And this ACMG guidelines uses a very complicated methodology to use supporting and strong criteria. We don't really need to remember all this, but there are tools available now which put all this into an algorithm to help us to classify every variant in basically these 5 categories. So let us see, one of the tool is something called Varsam, which you can again use in your clinic itself. And let us see how we classify this variant. So let us see this one particular variant in a patient. We got this as a stop codon variant. So this is a C2T variant which is causing stop codon. And this tool says that it is pathogenic, and the evidence used here is that this is a nonsense variant and it is not there in the normal populations and predicted as disease causing. So these all evidences will be written in the report that you get, and you should make an effort to read these evidences in the report Similarly, this variant is classified as likely pathogenic because it is a missense variant, it is not found in population, and at the same place another variant has been reported earlier in a patient with same phenotype. Whereas this variant, although it is a stop codon variant, we can see here that it's a null variant, but it is not classified as pathogenic directly because there is some evidence that it is likely to be benign. So we should always remember not jump at conclusion that all stop codons are pathogenic. And then we have another variant which is not there in population but predicted as benign, so it's likely benign, and this variant is very common in population, so it is classified as benign. So using these different rules, these all variants are classified. So let us see an example here. This is a patient of suspected mucopolysaccharidosis type 7, and we found this one particular variant in GUS-B gene. So the first evidence is that this is a homozygous missense variant in exon 5 that results in this amino acid change. So this is a location type effect kind of evidence. The second evidence is that this variant has not been reported in public databases like 1000 Genomes or Nomad. So this is the normal population database evidence. The next evidence is that this variant has not been reported in other patients of MPS 7 till now. So this is the known variant database variant, which tells us that this is a novel variant, and the pathogenicity prediction tools are predicting it to be disease causing. So this is the in silico pathogenicity prediction variant. And then the clinical features of the patient match with those described in MPS 7, and MPS 7 is known to be caused by mutation in GUS-B. So this is the most important genotype phenotype correlation variant. Now based on all these evidences, we ultimately can classify that this is a likely pathogenic variant because of the genotype phenotype match as well as all these other evidences. So all these things will be mentioned in the reports that you get, and you can make use of it. However, what to do when you get a variant of uncertain significance, and this I am sure all of you must be getting in your clinic. Best thing is to refer to a clinical geneticist. But if you want to further follow up, then very important to do Mendelian segregation in the family. You can check the variant interpretation yourself based on what I have told you just now. Or we can do something called very important reverse phenotyping, which a clinician can do in the clinic to look for features in the patient, or follow up the patient periodically to check for reclassification. But whatever you do, do not take irreversible decision like prenatal diagnosis, therapy, or genetic counseling based on a VOUS. So how do we do Mendelian segregation? So suppose you got a heterozygous variant in the patient. We do the same, we check the same variant in parents. If both parents don't have it, then it is a de novo variant, very likely to be pathogenic. However, if one parent has the same variant as the child, then it is very less likely because this parent, he has the variant, why he will not have the disease? So it is less likely to be pathogenic. Similarly, if we find a homozygous variant, a VOUS, if we find this variant in both parents, that means it follows the recessive inheritance, it will be likely to be pathogenic. But if one of the parent is a carrier and other parent is homozygous for this same variant, then again this variant is less likely because this parent is homozygous but not affected. Or sometimes you may get one parent to be normal on sequencing and the other parent carrier, and this can happen because of a large deletion. So we should check for large deletions when we get such a scenario. Similarly, if you get a compound heterozygous variant, that is two variants in the same gene in the patient, then again if we look in the parent and one parent each has each of the variant, then it is likely to be pathogenic. But if one parent is having both the variants same as in the child, then it is not likely to be pathogenic because these variants are in cis, they are on the same chromosome, and the other parent is not having any pathogenic variant, and so this is not likely to be disease causing. So this way Mendelian segregation can help us to further reclassify the variant. And another tool that is very useful is Franklin by Genoox, which all of you can try. It's a free tool which again does the same thing that I had shown earlier to classify the variants. What is reverse phenotyping is that if you find a variant of uncertain significance in Hunter syndrome gene, you can do the enzyme assay to look for enzyme deficiency. If you find a VUS in calpainopathy, we can do a immunoblot assay. Similarly, if we find a variant in ARID1B gene, we can look for the classical clinical features of hypoplastic absent phalange or Jervell-Nielsen syndrome where ECG shows QT intervals. So this is reverse phenotyping where we look for the specific clinical phenotype and then try to reclassify the variant. Or the reclassification may happen because of a novel gene is described which was not known earlier, or because new data has come up because of population frequency or functional assays. And these functional assays are done in research laboratories, but they do help us in reclassifying the variants using either cell line based assays or model organisms to help us understand the protein function. So let us quickly see a few cases where how a VOUS is dealt with. So this is a family which came with a ultrasound showing single fetus with short long bones, mainly mesomelia and vertebral segmentation defect. It was a precious pregnancy, and the exome sequencing in the fetus showed a homozygous variant of uncertain significance in the intronic region -11 position. So this is a intronic variant. We are not sure whether it is disease causing or not. So the first thing what we do is a reverse phenotyping. We see that the 100% patients of Robinow syndrome have mesomelia, and the gene that we have found the variant is the Robinow syndrome. So that is a very good clinical match. And the next we do a functional assay. We look at the cDNA in the RNA extracted from amniotic fluid, and that is showing that this variant is acting as a splice site variant, and instead of exon 567 we have exon 5 stitched to exon 7. So there is a evidence from the reverse phenotyping that the clinical features are matching and the functional assay is showing like it is a disease causing. So now the VOUS gets converted to likely pathogenic, and hence this couple continued the pregnancy knowing that because it was a precious pregnancy and there is no intellectual disability in this condition, so they could go ahead with the pregnancy. Similarly, we have this patient who had global developmental delay, retrognathia, posturing, and MRI showed this lissencephaly. So when we did exome sequencing, we found a VOUS in a gene, a homozygous VOUS in CDK5 gene, which is known to cause this kind of a phenotype of lissencephaly, but it is a VOUS, so we need further evidence. So if we put in Franklin that I told you, it shows that this is a VOUS because it is low in population and in silico prediction is there, but this evidence is not enough. So now we need to gather more evidence to see what happens, and we could do a functional assay because one of the scientists was able to do a functional assay for this variant. We won't go into details of this, but the functional assay showed that this causes a problem with the protein. So now when we add this additional evidence of population data in silico and functional studies, we can see that the evidence moves, the prediction moves from VOUS to likely pathogenic. So this is a very dynamic kind of classification. Based on additional evidences, we can change the classification of that variant. This is the last case which really shows us why we may cause more harm to the patient if we don't do our analysis properly. This was a patient who came to us with spasticity in lower limbs since 6 months of age. There was tiptoeing and patient was suspected as spastic paraplegia. When the exome sequencing was done, the laboratory gave a likely pathogenic variant in a disease called a Charcot-Marie-Tooth disease. So the first thing we do is a reverse phenotyping to see whether it matches the phenotype, although it is likely pathogenic. And we can see here the phenotype is totally different from the spastic paraplegia. This is a neuropathy kind of phenotype. The phenotype is not matching. Hence, although it is a likely pathogenic variant classified with the lab, you should take it with a pinch of salt and not take a decision. But here that was not done. Secondly, the parental segregation was done and father also was having the same variant. So we have seen that if father has the same variant, it is unlikely to be disease causing. However, this also was not seen. Just because the lab has given a diagnosis the pediatrician has labeled this patient as Charcot-Marie-Tooth disease. This patient went to the gynecologist. Gynecologist has done a prenatal diagnosis because pediatrician has labeled this as a likely pathogenic variant for this. And now the fetus is also found to have the same variant, and that is when the family came to us. Now this is really a tricky situation now. First of all, we don't know diagnosis in the previous child. It is not the diagnosis that is given, and now we cannot tell them whether to terminate this pregnancy or not. And when we checked the variant, we found that actually it was a VUS variant, and the laboratory had done a mistake by using a wrong transcript. So we can see that the genotype was not matching with phenotype. Unaffected father was carrying the same heterozygous variant. A wrong transcript was used by the lab, and prenatal diagnosis was done without understanding the variant. So the pediatrician, the obstetrician, the laboratory all failed in helping this patient really. And this is what must be happening in many of our patients. And hence it is very important that we make this little effort to try and understand how to interpret this variant. So every medical practitioner is going to come across all these kinds of variants of VOUS. When in doubt, please obtain opinion of your clinical geneticist colleague. Additional evidences can change the classification. Remember that. And hence it is very important to keep the patient on follow-up. But whatever you do, please don't take irreversible actions like referring for prenatal diagnosis, therapy, or genetic counseling based on a VOUS. So lastly, I would like to tell you about this important mission program in pediatric rare genetic disorders that we are undertaking along with Dr. Pradnya as one of the collaborators. If you have any patients with undiagnosed disease after an exome also, if it is negative, please do refer such patients to us for doing genetic testing on research basis, where it will be offered free to these patients, so that we can try to understand the genetics and identify novel genes. And secondly, I would like to tell you about the Indian Academy of Medical Genetics, where we have these 3-month fellowships for pediatricians who are interested in taking of medical genetics in future as their career. So thank you for patient hearing, and we can probably go for the case presentations now, and then we can take any questions.
Thank you so much, Dr. Ashwin, for explaining all the very complex concept of next generation sequencing in a very simple, clear, and concise manner. We'll be taking the questions, but before that, we'll have 2 case presentations by our DRNB senior residents, just to highlight the importance of the role of proper phenotyping in NGS data analysis and the role of reanalysis of the NGS data when we get negative results. Dr. Ashwin has already highlighted the various aspects or the various reasons for why you may get a negative exome. So the 2 illustrative clinical scenarios are going to show us what we should do when we get a negative exome. Of course, these are just 2 representative examples. There are several other things that we might have to do when we get a negative exome. So the first case will be presented by Dr. S. Wali. Dr. Wali, can you please share your slides?
Yes, ma'am. Yes.
So Dr. Valli is currently doing her DRNB in medical genetics in our department. That is the Department of Medical Genetics at NIMS, Hyderabad. She's in the 3rd year now. Dr. Valli, you can share it in
Yes,
full screen mode. Yeah. So she will be showing us the importance of data reanalysis if you do an exome and it comes negative, you need to keep these patients, either you immediately go ahead and do further testing, or you keep them under follow-up, and you can reanalyze the data over specific periods of time. And sometimes we find that on reanalysis, from the same data, we may get the results. So over to Dr. Valli.
Thank you, ma'am. Good morning. So I'll be presenting the first clinical scenario, which highlights the importance of periodic reanalysis of NGS data. So here our proband P1, a 16-year-old male patient, was referred from nephrology department for evaluation of steroid-resistant nephrotic syndrome. He was the second offspring of a 3rd consanguineous couple, and he also had a similarly affected 18-year-old female sibling. The first episode of nephrotic syndrome for this child was documented at the age of 9 years. He was put on steroid therapy, and following 2-3 months of daily prednisolone therapy, he was not showing any improvement. Therefore, primary steroid resistance was documented. This is a family pedigree of this child, and here the third consanguineous couple, he is our proband, and this is a similarly affected sibling. So here on examination, like during the first visit, we also found some other features common to both children other than nephrotic syndrome. So the children also had short stature and some dysmorphism, which I'll be discussing. So this, other than that, there is no significant family history. The course of the illness, when the child had the first episode, the documented C3 and serum C4 levels were normal. However, the initial anti-complement factor H antibody levels were significantly high, which is 573, with the reference being less than 20. And then the child was started on intravenous cyclophosphamide as well as fresh frozen plasma therapy. Even after 4 cycles of cyclophosphamide and 7 cycles of FFP, the child did not show significant improvement. Therefore, he was maintained on low-dose steroid therapy along with combination of enalapril, losat, and other supportive management. Over a period of time, like after 1 year, there was some, decrease in the anti-complement factor H antibody. There was also some subtle, subtle improvement, like in the form of increase in serum albumin to 3.2 gram per deciliter, reduction in urine protein creatinine ratio to 2.3, and the urine protein level also had come from 4+ to 2+. Therefore, the proband had a multi-drug resistant glomerulopathy-like picture. He was on partial remission, mainly on supportive therapy, and there was a possible doubtful role of immunosuppressive therapy in him. When he came to our genetics clinic, we examined him, and on examination, the child was found to have short stature, that is minus 4.12 standard deviation. His circumference was preserved, and the weight was on slightly on the higher side, plus 3.82 standard deviation. The upper segment, lower segment ratio was around 1, and his sexual maturity rate was 3. There was also some facial dysmorphism in the form of flat supraorbital ridges, mid-face hypoplasia, low set ears, slightly posterior rotated and overfolded helices, prominent hallucis, and deep set toenails, and myopia. And he also had atlantoaxial joint instability, for which some intervention was also done. And systemic examination did not reveal much. They were fine, and the ultrasound abdomen showed grade 3 renal parenchymal changes, and 2D echo was normal for the child. The X-rays were ordered in view of short stature, and then we found there was thickened calvarium, sloping ribs, then remodeling of the metacarpals, and overall osteopenia. However, the bone age was corresponding to the chronological age. This is a renal biopsy picture. Here we can see there are features suggestive of membranoproliferative glomerulonephritis, as the immunofluorescence showed minimal deposits of IgG, IgM, IgA, and significant deposits of C3. So C3 glomulopathy-like picture. Electron microscopy was ordered in for better characterization. However, the family did not do. Coming to the immunologic workup, there was elevation of anti-complement factor H antibody levels, which I have mentioned already. The ANA profile was negative, and the serum levels of complement 3 and complement 4, they were normal. Functional assay of the complement pathway, including all 3, the classical mannose binding lectin pathway, alternative pathway, they showed normal activity, thereby ruling out immune-mediated nephrotic syndrome. Examination of the elder sibling also showed similar features. She also had short stature, similar facial features with mid-face hypoplasia, and the renal biopsy picture was also like C3 glomerulopathy. However, she had a little milder kind of a phenotype because there was no myopia, no atlantoaxial joint instability, and no obvious skeletal findings. And her first episode of nephrotic syndrome happened at a slightly later age, like 12 years of age. So with all this information, the following possibilities were considered. Could be a monogenic nephropathy with associated extrarenal manifestations, or it could be 2 different conditions coexisting together, like a blended phenotype. The sibling's mother was asymptomatic, and she denied any history of renal condition in her or her husband. However, the father could not be examined because he had passed away, and no other known family history suggestive of any similar illness. So exome sequencing was ordered in 2015 for this child. And that time we could not find any variant related to his, pathogenic or likely pathogenic variant related to his phenotype. And then subsequently in 2018, from elsewhere, clinical exome was ordered for the same patient. And there they found a heterozygous variant of uncertain significance related to a condition called Schimke immunoosseous dysplasia. However, it is an autosomal recessive condition, and the heterozygous variant is not likely to have present any phenotype. Therefore, both exome sequencing and clinical exome sequencing reports were inconclusive for any definite genetic etiology. The patients, they completely lost to follow-up after that, and they came back in 2022. For them, again, the reanalysis of exome data was planned, and then if that was negative, then whole genome sequencing was planned subsequently. Upon reanalysis, we found this variant, a homozygous variant at the position C.196C2 in DAM2 gene related to nephrotic syndrome type 24. According to the prediction, according to ACMG guidelines, this variant was classified as likely pathogenic variant with the criteria PVS1, which is a null variant, and PM2, which shows a very low frequency in the population databases. Similarly, we checked on Warsaw, which also showed the same criteria, indicating a likely pathogenicity of this variant. The in silico prediction, to look for the 3D structure of this protein, also showed that there is some truncation. It's likely to be damaging. So just to show the various domains of this DAM2 protein. So here, this particular variant, which we have seen in the program, is situated more proximally. Here we can see this is the position of the variant, and the other variants which are starred in black. These are all the previously reported variants prior to this our case. Case, and on checking the phenotype, normal. The inheritance is autosomal recessive. Kidneys, there is an expected nephrotic syndrome with end-stage renal disease, focal segmental glomulosclerosis with effacement of podocyte food processes. Lab findings, lab abnormality suggestive of nephrotic syndrome. A lot of these features were matching the child's phenotype. However, the child had more of a membranoproliferative glomerulonephritis, which is not really expected in this phenotype. And effacement of podocyte food processes, this could not be demonstrated because the electron microscopy was not done though advised. And further, this does not explain the extrarenal manifestations seen in the children also. Extrarenal manifestations like myopia, atlantoaxial dislocation in the child, they were not well studied. The association was not well studied with this particular gene, and very few reports had been published that time. So this could still be a part of this DAM2 phenotype, which is like an expanded phenotype, or it could be a blended phenotype with some other monogenic disorder coexisting with this condition. So here we found some reports which showed a possible association of DAM2 variants with the abnormal bone formation metabolism. So DAM2 variant is an effector of the WNT signaling pathway that is known to regulate the bone metabolism and osteoclastic bone resorbing activity. So it is possible that the variants in DAM2 might have impacted the bone's homeostasis, contributing to the observed phenotype in this individual. With all these evidences, we considered this as a final diagnosis. So DAM2 associated autosomal recessive nephrotic syndrome 24 in this family. Following this, immunosuppressive agents were weaned off because we know it's not going to help very much. And he was only put on supportive therapy mainly. Targeted Sanger sequencing of the mother was done to confirm her carrier status. And it did show heterozygous carrier status in the mother. Father could not be tested because he was not available that time. He had passed away. The variants related to other monogenic conditions related to disorders of complement system were also looked for, but we could not find any significant variant. Similarly, no other copy number variation or no other additional variant related to other collagenopathy or skeletal dysplasia. So this was a novel variant, and the case was reported in 2024. Here we see, like I told, the position of this variant we can see here. This is our novel variant. And this has resulted in truncation of most of the protein domains of this DAM2 protein. And the study reports the fifth family globally and the first first one in India with DAM2 associated steroid-resistant nephrotic syndrome. So why there was a negative report, a negative exome or a clinical exome before? So the very association of DAM2 variants with nephrotic syndrome was published for the first time in 2020. And if you remember, the analysis was the first time when we did the exome sequencing and clinical exome, there was no sufficient evidence to show any association of this DAM2 variant with nephrotic syndrome at all. It was not well studied, in fact, not well studied before 2020. And DAM2 variants are known to be likely monogenic causes of human SRMS after 2020. And there is another reason why we prefer whole exome sequencing to clinical exome, because clinical exome has a limited number of genes to be tested, whereas whole exome will cover more number of genes. So the learning points from this case presentation would be, first of all, it highlights the importance of reanalyzing the exome data over a period of time, because with time there can be more evidence or more reports suggesting more association of variants with different phenotype and all that. And also it highlights the importance of doing a whole exome sequencing rather than clinical exome, because clinical exome can miss several other genes which are not known to be associated with that particular phenotype at that point of time. So we know that whole exome sequencing is not that one test for all genetic disorders. There are several reasons why whole exome sequencing can miss the variant, and reanalysis of, periodical reanalysis of whole exome sequencing is definitely very helpful. At least once in 6 months or once a year it is recommended. So reanalysis can be done by rephenotyping. That is, we can examine the proband periodically. We can ask them to come once in 6 months for a re-examination. And then we can also check the list of associated genes or the newly published associations, something we can also search. And then checking their raw data, the IGV and all that. And rarely, in some cases, it also the functional studies may also be done to confirm or to look for the significance of a particular variant. Last but not the least, the quality of data and coverage to rule out technical errors is also important that I have to keep in mind. So with this, I end my presentation. Thank you.
Thank you, Dr. Valli. So as we have seen in Dr. Ashwin's presentation and also Dr. Valli mentioned, there are several reasons for getting a negative exome. So one reason could be that the gene disease association is not known at this point of time, and that is why you may get a negative report. And over time, like as was highlighted by this particular clinical scenario, in 2017, when the exome was initially done, at that point of time, the association of this DAM2 gene with steroid-resistant nephrotic syndrome was not known at all. It had not yet been discovered. So naturally, when the data was analyzed, they did not think of looking for variants in the DAM2 gene because that association was not known, and hence it was given as a negative report. But we need to remember that the exome, when we do whole exome, it covers all the known genes. So at least the coding portions and the flanking intronic sequences. So although the variant was there, it was not reported because in 2017, the association was not known. However, the same data, when we have reanalyzed in 2022, by that time, the association of this DAM2 with SRNS has been discovered. So because the whole exome had covered that gene, the variant was there, and now we know that DAM2 is associated with SRNS. On reanalysis, the variant could be detected and reported. So that is the importance of analyzing the data, the NGS data, in your exome negative cases. You can just keep them under follow-up. One of the things can be that you can do a genome to look for the intronic variants, other variants which are not covered in exome sequencing. But here, for example, DAM2, even if we had done whole genome, the report would still have been negative because at that time, DAM2 was not known to be associated with SRNS. And now on reanalysis, 5 years later, by which time the association has come to light, we have reanalyzed it, picked up the thing from the existing data. So that's the importance of keeping these mutation negative cases under follow-up, regular follow-up, and periodically reanalyzing the data. So this particular clinical scenario was mainly to highlight this important aspect of the importance and the need for keeping these patients under regular follow-up and reanalyzing the data at regular periods of time. Typically, you could do this, or you could, if you're not able to do it on your own, you could request the lab to do it once every year if you have a strong suspicion of a monogenic etiology. Now, another brief case which will be presented by Dr. Pratyusha Dr. Pratyusha, please share your slides.
Yes.
So Dr. Pratyusha is also TRNB Medical Genetics Senior Resident from the Department of Medical Genetics LIMS. She is in her second year now. So she will be showing us a clinical scenario which highlights the importance of the role of a proper phenotyping when we are doing an NGS data analysis. Yes, Dr. Pratyusha, over to you.
Thank you, ma'am. Good morning, everybody. I'll be presenting the role of phenotype delineation in exome sequence analysis. So my patient is Miss MJ, who's a 7-month-old girl brought by her parents from a pediatric facility with chief complaints of recurrent chest infections from 1 month of age. The child was apparently healthy until 1 month of age when she developed excessive cry associated with fast and noisy breathing, and she was treated with nebulizations at that time. Later again, at 6 months, she developed cold and cough for 10 days, following which she developed fast breathing and refusal to feed. There is no history of vomiting, seizures, dullness of activity, or loss of consciousness, and she was taken to the hospital and admitted for oxygen supplementation and IV antibiotics. Her antenatal and birth history were uneventful, and also her developmental milestones were appropriate for her age. This is the pedigree of the family. It shows that she was born to a third-degree consanguineous couple. She has 2 elder siblings. The eldest one had passed away at 8 months of age. He had recurrent hospitalizations for chest infections, requiring admissions for oxygen support. And towards the end, or towards his demise, he was also on ventilator support. As per history, his developmental milestones were also appropriate, and there were no other records available for review. An elder 4-year-old male sibling is active and healthy. She was evaluated elsewhere initially, and her routine investigations with complete blood count, renal function test, liver function test, serum electrolytes, thyroid function tests were normal, and her metabolic screening with tandem mass spectrometry was also reported to be normal. She was also she's also undergone whole exome sequencing, which reported a missense variant, a heterozygous variant in the CFTR gene. So before we go into the interpretation of this report, I would like to briefly touch upon zygosity. So we call a person to be heterozygous or a heterozygous variant when the variant is present on only one copy of a gene, the other copy being the normal variant. And we call it to be a homozygous variant when the same identical variant is present on both the copies of the gene. And a person is called to be compound heterozygous for a variant if 2 different variants are present on the 2 copies of a gene. For autosomal recessive disorders to be manifesting or showing symptoms, the variant has to be present in biallelic state, that is either homozygous or compound heterozygous. And a heterozygous carrier of an autosomal recessive condition is expected to be asymptomatic and healthy and called to be a carrier for that specific disorder. But for autosomal dominant disorders, a heterozygous individual will also manifest the symptoms related to that disorder. And ACMG criteria for variant classification, already Ashwin sir has told, we classify the variants into benign, likely benign, uncertain, likely pathogenic, and pathogenic. And the actionable variants are likely pathogenic and the pathogenic variants. So when we look back at the report, this is a heterozygous variant in a condition known to be following an autosomal recessive pattern of inheritance. So this is unlikely to cause symptoms, and this person is likely to be a carrier for this variant in the CFTR gene. But when we also look at the classification, this is from Warsaw, it is also predicted to be likely benign and unlikely to manifest symptoms related to cystic fibrosis. So with these 2 evidences, this was considered to be an inconclusive report. So we further examined the child. Her anthropometric measurements were normal, and the child was alert. There was no paler icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. And she had subtle dysmorphism in terms of long face, bilateral drooping eyelids, downturned angle of mouth, and a high-arched palate, suggestive of myopathic facies. And her CNS examination showed bilateral ptosis, impaired extraocular movements, and motor system examination showed normal bulk but hypotonia of all limbs, and power was normal, and deep tendon reflexes were diminished, which were 1+. The remaining systemic examination was within normal limits. To summarize, this was a 7-month-old female girl child with normal antenatal birth and developmental history with complaints of recurrent respiratory infections requiring admission since 1 month of age, with similar complaints in eldest male sibling who passed away at 8 months of age, and her examination findings showed myopathic faces with bilateral ptosis and impaired extraocular movements, hypotonia of all limbs with diminished deep tendon reflexes. So when we look at the differential diagnosis, based on the clinical history and examination findings, if we are looking only at the recurrent respiratory infection, we could think of possible primary immunodeficiency disorder, cystic fibrosis, or primary ciliary dyskinesia. When we also look at additional findings of ptosis and hypotonia, this would suggest a genetic disorder with neuromuscular involvement, likely to be congenital myasthenic syndrome, congenital myopathy, congenital muscular dystrophy, or mitochondrial myopathies. To narrow down the clinical diagnosis further, we ordered further ancillary tests, and this is as follows. The 2D echo was normal. Total creatinine phosphokinase and serum lactates were normal, and serum electrolytes, including calcium, was normal. But the repetitive nerve stimulation test showed a decremental response to compound muscle action potential. So when we add these investigations, the genetic neuromuscular disorders were most likely, and out of these, congenital myasthenic syndrome was the most likely clinical diagnosis of this child. So we got the raw data files from the lab and to reanalyze the data for these, any variants related to these. And before we go into that, when we look at a raw data, when we look at a TSV file, it is generated like an Excel with all the variants detected in a list. And for a person per exome, we get about 50,000 variants. And to look at each of these variants and see if it is causative of the disease or not is like searching for a needle in a haystack. So our child, this is the representative of the Excel sheet of our child, which shows about 33,000 variants. And to make the method of filtering the variants easier, so there is a criteria which sir has already explained. We look at the quality filters, and then we look at the population databases, the healthy population databases where the variant is present or absent in those databases, previously reported cases, if any other individual is reported with the same variant, and the location of the variant, whether it is exonic and splice, which is most likely causative of the disease, and the functional effect of the variant based on previous functional evidence or predictive tools, if the other evidence is not there. And then finally, the inheritance and the zygosity of the variant and genotype-phenotype correlation. So this was the filtered file of the child where we had applied for the quality filters, minor allele frequency, and the variant location and functional effect. And we had come down to 69 variants. So from this, we have to look at the phenotype-genotype correlation. So what we understood is maybe the initial phenotype that was provided is recurrent respiratory infections. So to make the laboratories to have a homogeneous way of analyzing the data, there is something called human phenotype ontology or HPO. For each clinical finding or laboratory finding, a standardized term and ID is assigned so that all the labs will follow the same term for the finding. For example, when you look at the word ophthalmopharesis, somebody may call it weakness of extraocular muscles or extraocular muscle palsy or paralysis. So there is a single term and ID for that finding. So we have additional phenotype handles after our examination, which is bilateral ptosis, limited extraocular movements, and incremental response of compound muscle action potential on ENMG. So we applied bilateral ptosis as one of the filter, and from 69 we had gotten 2 genes, that is the COL-Q gene and the TUP3 gene. And when we also apply limited extraocular movements, this can be done as the same step. We came down to only 1 gene, which is the COL-Q gene. So this COL-Q gene related variant is a C.1099 duplication in a homozygous state associated with autosomal recessive congenital myasthenic syndrome. So one is this, and when we look at the ACMG criteria, This is a frame shift variant and it causes premature truncation of the protein. And also this is not present in the healthy population database. So it satisfies the pathogenic criteria also, and also the allelic state required for an autosomal recessive disorder. And the other variant in the CFTR gene is not likely to be the diagnosis, and the final diagnosis was autosomal recessive congenital myasthenic syndrome. So we know that the severity and the course of congenital myasthenic syndromes is highly variable, and it may range from mild symptoms like ptosis or mild weakness, muscular weakness, to progressive disabling weaknesses or respiratory insufficiency. And these severe weakness or episodes of respiratory insufficiency may be precipitated by infections, and especially in case of neonates, and this may be life-threatening. So it should be considered as a possible diagnosis in every patient with unexplained recurrent respiratory infection, or when there is an unusually severe course of mild respiratory infection, especially when the periods in between these episodes, the child is almost normal. And early diagnosis of congenital myasthenic syndrome is crucial for early treatment and may help avoid sudden infant death and severe molecular testing for CMS is important because it guides the choice of medication depending upon the mutation identified. For COLQ-related congenital myasthenic syndrome, which is an end-plate acetylcholine deficiency, beta-2 agonists are given, and acetylcholinesterase inhibitors like pyridostigmine may be ineffective or even cause deterioration of the symptoms. And surveillance of the muscle strength and respiratory function, especially nighttime hyperventilation, should be done for every 6 months in a child and annually in case of adults. And drugs which exacerbate the neuromuscular weakness should be avoided, and supportive care is given based on individual's requirement. Physiotherapy is given for improving the muscle strength, orthotic support in case of joint contractures, and percutaneous gastrostomy if there is feeding difficulty in the child, and ventilatory support is given in case of severe respiratory weakness. So to counsel the parents, we know it is an autosomal recessive disorder. So in every pregnancy of the couple, of a carrier couple, there is a 25% chance of each offspring being affected. And to prevent this, we can do prenatal invasive testing in every pregnancy, which can be done either by chorionic villus sampling at 11 to 13 weeks or by amniocentesis between 16 to 20 weeks. So the take-home message is that deep phenotyping is extremely important. If you're not able to give complete information or specific phenotype handles to the laboratory, they cannot filter the variants appropriately or interpret the variants. So this would thereby give a negative or an inconclusive report. And also the importance of reanalysis. If there is a really strong suspicion of a monogenic disorder and the report is negative, we can reanalyze immediately with better phenotype handles and try to arrive at a diagnosis. With this, I end my presentation. Thank you.
Thank you, Dr. Pratyusha. So this clinical scenario was shown to highlight the importance of proper phenotyping. So despite the availability of all these advanced tools, NGS-based tests and all, there is no alternative to a detailed clinical phenotyping. And your clinical acumen finally remains above everything else. So, and also the case highlighted the importance of an accurate genetic diagnosis in order to initiate the accurate management procedures and also for appropriate counseling. So with that, I think we can take the questions if we have time. And Dr. Ashwin, would you also like to add something related to the two clinical scenarios, following which we can quickly take the questions?
Yeah, so these two clinical scenarios basically bring out the same thing that in the first case, it is about the importance of follow-up of the patient. So that is very important that we explain to the patients that if we did not find anything or if there is a VOUS, things might change over the next year or so, and it's important to keep them under follow-up. So I think the aspects discussed in the talk were brought out by these two cases in the end. So quickly, some of the questions I already answered in the chat, but if there are any more questions, we could quickly have them.
Sir, already you had answered most of the questions, sir. And I want to thank Prajna ma'am, and behalf of PATS, I want to thank Ashwin Dalal, and also beautiful case presentations by Pratyusha and Vali also, who are the senior doctors in their post-graduation. And all the best for their postgraduates. And second thing, there's a good participation in the delegates also. And last but not least, I want to tell again, every link is available in the YouTube. If you are missing the sessions, you can really open the YouTube and watch the same video leisurely. So, and once again, we have to thank from PATS, Dr. Prajna Rangnath Madam, who had taken utmost care and bringing all the national faculty onto the every month webinar. So thank you, ma'am. Thank you so much. And and Bhaskar sir and RSV are not there. On behalf of PATS, I want to thank everyone who had. Thank you. Thank you once again.
Thank you so much.
Thank you,
Thank you,
sir.
Dr.
Thank you,
Ashwin.
ma'am. Yeah.